And I'll just introduce Laura while she sets up. Laura is a senior research fellow in the Division of Population Health at the University of Sheffield. Her research interests include how we measure obesity at different life stages. Her PhD focused on childhood obesity. Her recent MRC fellowship investigated obesity in older adults, and a recent award from the European Association for the Study of Obesity funded this work into different measures of obesity across the life course. So go ahead, Laura.
Thank you. Can you hear me?
Yeah.
Okay, brilliant. Firstly, I would like to apologise if there's any banging. We're having our roof done at the moment, and so there might be a little bit of banging in the background, but I'll try not to let it put me off. So thank you for the introduction. I'm Laura, and I'm going to talk to you today about obesity trends in England. And the study that I'm talking about uses data from the Health Survey for England. So I'll talk a little bit about obesity in England, a little bit about different obesity measures, and then about how we use the data from the Health Survey for England to disentangle the drivers and what's driving the trends that we're observing. And then I'll briefly touch on what our findings mean for policy development. So obesity is a significant and growing public health concern, not just in England, but across the world. In May 2023, the government statistics for England stated that 26% of people living in England were living with obesity, and a further 38% living with overweight. And this proportion is slightly higher in men, and it varies with age, and there's huge inequalities in socioeconomic groups and ethnicities. And we know that the risks associated with obesity increase with age, and so as we see an increasingly aging population, this could have a significant influence on the trends in obesity that we see in the future. So this study uses data from the Health Survey for England. There are a number of advantages of using the HSE to analyse both trends in obesity as well as using age-period-cohort analysis, which I'll come on to later. So in relation to the data on obesity, the Health Survey for England includes BMI, so height and weight, for both adults and children. But crucially, it also includes waist circumference in adults and in children over 12 years. And this allows us to compare different measures of obesity to determine obesity trends when we're using different measures. So in terms of using an age period cohort analysis, which I will go into more detail about later, the annual data provided by the HSE makes analysing trends and disentangling the drivers of these trends a lot easier. And also the Health Survey for England has because we can look at a big age range, that really helps with this type of analysis as well. So this figure is taken from a previous article, which also used data from the Health Survey for England. And we can see differences in obesity trends since the early 90s. So it shows that obesity, the prevalence of obesity, that's the increasing line we can see here. So that's been steadily increasing since the early 90s. It also shows a decreasing line, which is the prevalence of a healthy weight. So that's coming down at a very similar rate to the rate that obesity has increased. And the fairly consistent line at about 38% is the prevalence of overweight. And so because the increase in obesity is kind of mirrored by the decrease in healthy weight, this suggests that people are moving from overweight to obesity at the same rate that they're moving from a healthy weight to overweight. And so this suggests that there's a shift in the entire BMI distribution across the entire range. So this figure is taken from the same article as the previous slide, and it shows how the odds of obesity change with age, again using data from the Health Survey for England. So again, obesity is defined using BMI. Sorry, I should have said anything above a BMI of 30 is defined as obesity in this figure. And we can see a steep increase throughout early adulthood and middle age before this reverses in older adults. So this decrease in the odds of having obesity in older adults is counterintuitive. And when we think about what we know about risks associated with obesity, they continue to get riskier as people age, and that doesn't start to decrease in older age. So obesity-related diseases such as diabetes, cardiovascular disease, a range of cancers, they all continue to increase as people age. So this suggests that BMI as an indicator for obesity might be misleading in older adults. So in that specific population, it might not be the best measure to use. There's a few different possibilities for this, but one of the obvious reasons is that BMI doesn't differentiate between muscle and fat mass. And so as people get older, they can lose muscle and their weight decreases, and therefore their BMI reduces, but their body fat percentage is actually increasing. And it's for this reason that we want to look at trends in obesity, not only using BMI thresholds, but also using a range of other measures that might be more appropriate in later life, sorry. So the measures that we're going to use, BMI has been traditionally used. It's well known by patients and the public and clinicians. Generally, a person is defined as having obesity if their BMI is above 30 kilograms per meter squared. There that varies during childhood. For children, there's an age and sex-specific growth charts need to be used, and also there are different thresholds for certain populations, including people with different ethnicities, so that does complicate things a bit. So what are the alternatives to using BMI? We investigate measures which use waist measurements, sorry, and therefore specifically measure central obesity. Central obesity is thought to be a more important marker for health than general obesity because it more accurately determines where on the body fatty tissue is distributed, and it's less influenced by muscle mass. So we investigate the measures shown on the screen. We investigate waist circumference, which has established thresholds to define obesity or high risk, which are different in men and women. And these thresholds also differ by children, by age and sex, but they do differ less than BMI. We also investigate waist to hip ratios. Again, these thresholds differ between men and women and vary throughout childhood. Again, a bit less than BMI do. And lastly, we investigate waist to height ratios. So this measure has the benefit of one size fits all. It's considered to be the same for adults, both male and female, and for children. And this measure has also been recently endorsed by NICE for use alongside BMI in clinical settings and also for use at home. And they state that the ratio of over 0.6 indicates high central adiposity and further increased health risk. So there are, for all of these measures, these are the highest thresholds that are used. There are these are the ones defining obesity. There are equivalent ones for overweight that are slightly lower, but we in the study just look at the higher thresholds. So as I mentioned earlier, we use data from the Health Service for England across 4 different obesity measures. This figure shows the proportion of people in England considered to be high risk using each of the measures and their thresholds as described on the previous slide. We didn't use any data prior to 2005 because waist circumference was not collected in children until that time. And we felt that for this study, it was more important to look at as wide an age range as possible. So the figure shows the trends over time for each measure. And as you can see, BMI and waist to height ratio show very similar prevalence, suggesting that at least at a population level, they're measuring the same thing. Waist circumference and waist to hip ratio show higher prevalence across all years, but all measures show an increase over time. Most measures show a small uptick after the COVID-19 lockdown, but this isn't present in BMI, and there could be a few reasons for this. We haven't explored this too much. But what this doesn't tell us is what's causing these increases in obesity over time. Whatever measure we use, it's increasing, but it doesn't tell us why. Is it because the population is aging, so we're getting more unhealthy? We know that obesity-related risk does increase with age. Is it due to changes in the environment, influences that are happening at any given time, obesogenic environments social environment at the time? Or could it be generational effects? So the different cohorts that have different susceptibility to obesity. And in reality, it's likely to be a combination of these things, but this study aims to disentangle these effects to determine which of these plays a bigger or smaller part to help design policy with the knowledge of what's driving this continued increase in obesity. So to recap, we aim to disentangle these three effects: the age effect, how the prevalence of obesity changes with age; the period effect, the environment at the time; and the cohort effect, the generational effect. However, there is a problem, because for every year that goes by, that is an increase in 1 unit of the period. All individuals get older by 1 year, and each generation is 1 year older. And this means that there's perfect collinearity when trying to estimate these effects on the prevalence of obesity. So to get around this problem, we use an age-period cohort analysis, which effectively groups individuals into 3 variables, allowing us to break this collinearity and disentangle the effects. So within the Health Survey for England data, we use individuals born between the ages of 11 and 89 years, for the reasons discussed earlier. And there was a bit of data over the age of 89, but it was limited and caused very large confidence intervals. So to keep our results meaningful, we restricted the sample within this age range. The Health Survey for England already has age groups incorporated into it, so we've used those. And they're mostly 2-year age groups with some larger groups in children. So some age groups contain 3 years, most of them 2. We use data from 2005 to 2021. Again, mentioned earlier, before 2005, there were no waist measurements taken for children. And we group these time periods into 3-year periods. So by restricting our sample as described, we're left with individuals born between 1919 and 2008. Sorry, there is a typo on the slide there, it should say 1919. And we group these into 5-year birth cohorts. So by splitting each of these 3 variables into different size groups, we can remove the collinearity and make it possible to estimate each of these effects. We put these categorized variables into a logistic regression to predict high risk in each of the different measures. So that's 4 different logistic regression models. So these figures show the prevalence of obesity using each of the different measures and how they change with age. Each of the different coloured lines shows a different cohort, and all the cohorts appear to follow a similar trajectory. The line is quite smooth between the different cohorts. We can see an obvious increase in the prevalence of obesity across all measures until around the age of 60. And at this age, the waist-based measures continue to increase, but BMI starts to show a levelling off and then a decrease in the prevalence of obesity after this age. So this again highlights the potential risks of using BMI alone to assess health risks, suggesting that older people are at lower risk of obesity-related diseases, and we know that this isn't the case. The other measures, particularly waist to height ratio, show a very linear relationship.
Laura, just 2 minutes left.
Okay, yeah, okay, thank you. Yeah, so the waist to height ratio is a lot more linear, showing that it might have a more intuitive, show a more intuitive risk. So these are the results from the age-period cohort analysis. Here I've just shown them for waist to height ratio and body mass index, and that's just in the interest of time. So as you can see, both measures, the age effect is the largest influence. Obesity measured using waist to height ratio significantly increases by age. But again, we do see this levelling off and decrease for BMI. Period effects are similar across all measures and show a steady increase over time, although it's less than the age effect. And we find no cohort effect, so the generations don't seem to have much difference. So our results show that between age period and birth cohort, age plays the most significant role in analysing long-term trends in obesity. And this, coupled with the fact that the trends appear to be consistent across generation, suggests a substantial rise in obesity throughout an individual's life could hinder population capacity for healthy aging. Our results also support the use of interventions aimed at children and adolescents, if the aim is to reduce prevalence of high risk in any of the obesity measures during adulthood. However, there is also they also support the need for a specific approach to understand obesity at older ages and how best to measure that. So the takeaway message from this study is that age plays a significant role in driving obesity trends, meaning an aging population could lead to further increase in prevalence of obesity and an increased burden of disease, and also that BMI might not be the best measure for health, obesity-related health risk in older adults. So finally, I'd just like to say thank you for listening, and also thank you to the Health Survey for England, and also my co-author Magdalena, who has been a pleasure to work with on this.
Thanks, Laura. That's perfect timing. Thank you. The presenter, who is Stephen Jivraj. If you could share your slides, Stephen, and I'll read out your very short bio. Stephen is an associate professor at the UCL Institute of Epidemiology and Healthcare with research interests in social and spatial inequalities in later life.
Yeah, feel good.
Yeah.
Yeah, fantastic. Thank you, Vanessa. Yes, so my name is Stephen Jivraj. I should just acknowledge my co-authors before I start telling you what we're talking about here. And they are Hwa-Jung Choi and Kurland Wu, both from the University of Michigan, and the funders of this research, which is the National Institute of Aging in the US. So as Vanessa said, looking here at differences in cognition and the independence of living in coastal areas and inland areas, looking at data from the US and for England with a focus on people of pre-retirement age. The research on the relationship between health and coast is very well developed, and sort of speaks to sort of historic imaginations of the coast of being places where you can go to reinvigorate your health or keep it at a good level if it's already good. But there's been a bit of a sort of change in sort of contemporary thinking, with coastal areas being, particularly in England, some of the most deprived parts of the country, and therefore, unsurprisingly, shown to have places of poor health. And the same is true to some extent in the US as well, with areas around the Gulf Coast having much poorer health than other inland communities in other parts of the US. And so this is we think really important, particularly in relation to cognition and sort of independent living, because there's a sort of national debate at the moment around people of these ages not engaging with the labour market to the same extent as they did in earlier born cohorts. And so looking to see what's associated with that, is it related to their cognition and their ability to live independently, is a sort of area of hot topic. And so looking to see whether there's any relationship to the coast is important. So our central research question is, are older working age adults living in coastal areas less independent and more cognitively impaired compared with those people living inland? The data that we use come for England from the English Longitudinal Study of Aging, which we heard about this morning, so I won't say much more about that. And the data for the US comes from the Health and Retirement Study, which is actually a sister study of ELSA. In fact, it's a study that ELSA was modelled on, has been running for a little bit longer time. But in the case of both studies, they broadly include samples of people aged 50 and over and track these people over time as part of the panel, with refreshments coming at routine time points during the survey's period. Here we've restricted our analysis because we're looking at our pre-retirement ages of people 50 to 64. And in ELSA, we're looking at people from the very first wave of ELSA up to wave 9, and in the health and retirement study from wave 6 to 14. So same number of waves in both studies, and it cuts across the same period between 2002 and 2018. For each individual respondent in the data, there's only a maximum of 7 follow-ups, because if someone participated even in the first wave of ELSA, they would have come out of our age restriction by the eighth wave. So each individual respondent could only contribute a maximum of 7-person waves here, but some may contribute as few as 1 if they've dropped out of the study or have dropped out of the age range because they started older than age 50 at the very first wave we're looking at. In terms of our 2 outcome measures, we've got harmonized measures which are collected and asked about in exactly the same way in the 2 studies. So we first have cognitive function, which is measured through a word recall score, where people, I think, are given a list of 10 words and they're asked to immediately recall them. And then I think it's a delay of usually about 30 minutes later, they're asked to recall them again. And so we have scores there for people out of 20 on that measure. And then we also have a binary measure of the presence of something called instrumental activities of daily living limitations. So these are things like being able to conduct your own finances, go out and do your shopping. So these 2 measures sort of combine us, like I say, at the start, trying to sort of get as an indication of people who can not just purely live independently inside their house, but live their lives perhaps outside the house more independently, and in particular, be able to engage in the labour market. Identifying coastal areas, you would think on the face of it that that's something really easy to do. I think we generally sort of all agree what a coastal settlement is and what a coastal settlement isn't. It needs to be close to the coast. But actually doing this with data is actually quite hard. It's much harder than you would think. So I show this not to insult your intelligence of where the coast is in England and the US, but to identify how we've identified whether someone is living on the coast or not. So in England, we use middle level super output areas, census output geography of about 7,000 people on average. And we identify MSOAs as being coastal if they are within 500 meters of the UK statistical coastline. So you'll see there from that image on the left-hand side there, for the 9 regions in England, every one of them has MSOAs on the coast, with the exception of the West Midlands, which is completely landlocked by other English regions, and to the west by Wales. And also London doesn't have any MSOAs identified as coastal here. So places like Gravesend on the Thames estuary, that's not part of the statistical coastline, yet there are other areas out in towards Essex on the Thames estuary which are considered as coastal. So that's sort of where you get into this sort of vagaries around what is coastal and what is not. In the US, we've used a census output geography called census tracts, and we've identified again census tracts which are within 500 meters of the US statistical coastline. And then the US on the map there is separated into what the US Census Bureau calls its statistical divisions. And so for all of those statistical divisions, there are census tract with coastal, with census divisions with census tracts which are coastal, with the exception of the mountain division, which borders Canada to the north and Mexico to the south. There is one division there, West North Central, which only has a very small number of census tracts in Minnesota, which are on the one of the Great Lakes in the US, which is another point of contention I'd just like to raise here, is that we've identified places around the Great Lakes on like Michigan and Ontario as being coastal, even though they're not really on a seafront, they are on a lakefront, which we've done this because the US statistical coastline deems that part of the country as being coastal. And for the analysis I'm going to present, which is by region, it doesn't really have much of an effect anyway, because we're comparing coastal within each of these regions. There is one sort of problem here around New York, which, if you've ever traveled within the States, you'll know that New York has a boundary on the north on Lake Ontario and also around New York City on the Atlantic coast too. But that's how we've identified coastal points. So the methods that we've used here, we've used random effects models with linear models for cognition and binary logistic models for IDL presence. Our main exposure is this coastal identifier, and we have covariates in the model for age, age squared, sex, race in HRS only. And the results I'm going to show you only include those covariates as well as region, as I'll show you as well. And I'll talk a little bit more in the conclusion about what happens on adjustment for individual household income and area deprivation too. The models that I'm going to show you all have interactions between age and coastal areas to see whether there's any difference over age in whether someone's living in a coastal area or not, and also include interactions with region to see whether there's any regional differences. There's about 10,000 people in ELSA that we use and 20,000 in HRS. Okay, so to some results. So what you're looking at here are differences in the recall score within each region in England by whether the MSOA was coastal or not. So just starting with the top there for the Northeast, the fact that that Northeast estimate sits below 0 is saying that people who live in the Northeast in a coastal area on average have a lower cognition score compared with those living inland when controlling for the demographic characteristics I've just described in the previous slide. But you can see there that the confidence interval goes over 0, so it's not statistically significant. In fact, the only region with a statistically significant difference between its coastal and inland areas is the Southeast, showing there that places in the Southeast which are on the coast, people in those places generally have a lower cognition score compared with people living inland. In the US, hard to see what's going on here, and slight apologies for the presentation here because you'll see that Northwest Central division there, which includes Minnesota, has a very wide confidence interval, and the reason why I haven't corrected this is because it takes quite a long time to use these data in the safe setting and then get them approved. And so I have actually submitted a request for a revision to this output, but sort of weeks later, I'm still waiting for it to be approved. So having to work with what I've got here. But if you're very eagle-eyed, and I'll point it out anyway, you can see the divisions where there is a statistically significant difference in the cognition score. And generally, what we see here is that people who live in coastal areas in the US, in the south of the country, as well as the Pacific coast, generally have better recall scores if they live in a coastal area. Whereas people that live in northern states, if they live in a coastal area, they generally have lower cognition than people that are living inland. In terms of instrumental activities of daily living in England, as we see here, so we're looking at the plots in a slightly reverse way to the cognition. So here, sitting above 0 indicates a higher probability of the instrumental activity of daily living presence. And so just taking the two significant estimates we see there. So firstly, for the Northwest, what that is showing is people who live on the Northwest coast of England have a slightly lower probability of an IADL limitation than people living inland. But for the east of England there, what we see is a higher probability of IADL limitation compared with people living inland. In the case of the US, not much going on at all, except for the South Atlantic division, which is largely comprised of the state Florida. And so around that area, people who are living in Florida and the surrounding states typically have a lower probability of an IADL limitation if they're living in a coastal area compared with inland areas.
Stephen, just 2 minutes.
Sure, thanks. Yeah, thanks, Vanessa. So final slide. So just to say, there are these differences in cognition and IADL limitation, but really they are only borne out when we look at these regional variations. And in the UK, it's generally the sense that in more northern parts of the country, it appears to be there's some sort of protective effect of living on the coast, whereas in the south, it's the reverse. Whereas in the States, sort of the other way around. The southern areas, there tends to be some sort of protective effect. Northern areas, there seems to be a detrimental effect. But I said that in all these models, we hadn't controlled for socioeconomic status, either at the individual level or the area level. When we do, everything here becomes not statistically significant. Now, I don't want to sort of hide behind that and say, okay, this is all about socioeconomic status, because what do you do about that as a policymaker? How do you improve socioeconomic status? I mean, we can all think of ways that could be achieved, but they're unlikely to be taken up by policymakers. So we think the pure identification of these differences when controlling for demographic characteristics is of sort of public policy concern, and perhaps could be targeted in the ways in which we try and improve health, which is generally not through improving socioeconomic status, but targeting in particular places, like in the south of England, where the effect seems to be worse on the coast. Last thing I'd just like to say is the next piece of work I'd like to follow up this with is by looking at the difference is when we take account of selective migration. So what's going on here? I mean, are people who are less healthy tending to move to the coast in the south of England relative to the people that live inland in those places? And is it the reverse in the north of England? And in the case of the States, are people moving to sort of the classic retirement destinations, Pacific coast, Florida, if they are more healthy than the population that lives inland in those places, and the reverse in northern states? So I'll stop there, Vanessa.
Thank you again, Stephen, and we'll move on to our final presentation. So that's Jess Kurland, and if you could share your slides, Jess. Stephen, you'll have to stop sharing, I think.
Yeah, I'm trying to figure out how to do that. There we go. Sorry.
And I'll just introduce you, Jess, as you get your slides up. So Jess is a final PhD student co-funded by the ESRC and the Health Foundation. Her research explores the clustering of multiple long-term conditions and investigates how socioeconomic position modifies the relationship between clusters, healthcare use and mortality. Using data from ELSA and linked hospital records, her work aims to investigate social inequality in the burden of MLTCs and its impact on health outcomes. So over to you, Jess.
Great, thanks so much. I kind of I forgot what was in my introduction, and I think it did probably explain what I was just about to say. So anyway, as was said, I'm a final year PhD student at UCL, and today I'll be presenting part of the research that was formed part of my PhD, which looks at multiple long-term condition clustering, specifically socioeconomic inequalities and the impacts of these different clusters on a variety of outcomes. And today I'll be focusing on hospital admissions. So before I get into my research, I want to just talk a little bit about the background in terms of both social inequality and multiple long-term conditions. So here is my very basic illustration of the process of aging, and we can see that we have these kind of like two long-term conditions. So the aging population means that more and more people are living with not only one long-term condition, but multiple long-term conditions. And there's a lot of interest in trying to figure out kind of what determines whether people get long-term conditions and whether or not there are socioeconomic inequalities in the development of these multiple long-term conditions. So thinking about whether or not certain groups have higher risk of developing multiple conditions, if they have earlier ages of onset, are there differences in the types of conditions? So these are all areas where there's been quite a lot of work in terms of social inequalities, and there's a fair amount of evidence to say that there are social inequalities in the development of multiple long-term conditions. The area that there's been less work on, however, is looking at inequality in the impacts of multiple long-term conditions. So thinking about people who have multiple conditions, are they affecting everyone in the same way? And some impacts that we could think about things like well-being, we could think about biological impacts. We can also think about healthcare use, and what I look at is hospital admissions and things like mortality. But what exactly do we mean by impacts, and why are they so important to study within the context of multiple long-term conditions? So to go into this, let's just start by thinking of a single long-term condition, and let's consider all of the things that go along with having a long-term condition. We can think about the biological impacts, we can think about the treatment requirements, the symptoms someone experiences, how they're engaging with the healthcare system, and also the different things that they have to do on a day-to-day basis to manage their condition. So that's just one long-term condition. Obviously, today we're talking about multiple conditions, so we can go ahead and add in a second condition right next to it. Now, our traditional approach to healthcare, both in practice and in research, focuses on a very single disease or single system focused paradigm. So you can think about that in practice in terms of the different specialities in a hospital. In research, you could think about the different single disease or single system journals. If we were to apply that kind of thinking to understand the impacts of multiple conditions, you might think that we can just take the impacts of one condition, add it to the impacts of the other condition, and then there you have the impacts of both conditions together. However, unfortunately, it's not usually this simple. And instead, what we find is that we get the conditions interacting and impacting each other in a lot of different ways. So, for example, we could think about how the symptoms of one condition, something like joint pain from arthritis, would impact someone's ability to manage another condition, like engaging in physical activity to help their diabetes. So in reality, we have this really complicated network where we're getting interactions between a lot of different kind of domains of each of the long-term conditions. And this is only 2 conditions. In reality, it could be 3, 4, 5, however many conditions. So it's really complicated network, which leads to this idea of the impacts of multiple conditions can be more than the sum of their parts. So we're not just adding up the impacts of each condition separately. We always need to be remembering that it's multiple conditions in the same person at the same time. This also highlights why it's so important that we're using this kind of idea of a cluster-focused approach, where we're actually thinking about which conditions are co-occurring together, because obviously the way that the conditions are interacting will depend on which condition someone has. So we can then take it a step further and start thinking about, okay, could socioeconomic factors influence how people are experiencing these interactions between different conditions? So could someone's socioeconomic position, their access to wealth, resources, time, education, all of these things make it more or less difficult to manage and deal with multiple conditions? So with that, we can start thinking a bit more about what is already known about socioeconomic inequality and the impacts of multiple conditions. I said at the beginning, not much has been done on it, but a little bit has been done. So I kind of went through all the studies there were and found that you could group the findings into 3 main types of inequality. So the first is this idea of a cumulative inequality, where both multiple long-term conditions and a social factor, I'm just going to keep using socioeconomic position as the example, are associated with some kind of outcome. Let's use mortality as the example. So we find that people with multiple conditions and people with lower socioeconomic position both have higher risk of mortality. There's no interaction between the two, but they do kind of add together. So the people with the highest burden of mortality will be those with the multiple conditions and the lower socioeconomic position. So that's one type of finding. The second type of finding is this multiplicative effect, which is where there is an interaction between multiple conditions and socioeconomic position. And we find that the effects of multiple conditions on something like mortality are actually worse for people with lower socioeconomic position. And the third type of finding is another type of interaction, which is quite different. Instead, we have this leveling out effect, where again, there's this interaction, but we can think about it. We have a social inequality in something like mortality among people with lower numbers, so like 0, 1, or 2 conditions. But then as we're looking at people with more and more conditions, we find that this difference, this socioeconomic gradient kind of levels out among people with more conditions. So we call this a leveling effect. So there are obviously 3 quite different findings, which leads to the question of why are we finding such different things? We have the kind of usual answers that we've got differences in data, differences in population. But I think when it comes to this topic, the main thing is always going to be differences in methodology. So especially what we mean when we're talking about multiple conditions and how they're defined and measured. Are we looking at counts of conditions? Are we looking at clusters? If we're looking at clusters, which ones are we looking at? All of these kind of things mean that we still need to do quite a lot more research in this area to figure out what's actually going on. So with that background, I can get on to some of my research aims. So sorry, I'm actually just gonna pop in my other headphone because I think this one is about to die. Hopefully you can still hear me. So the research aims. The first aim was to group older adults into distinct and clinically meaningful clusters based on their patterns of long-term conditions. The second aim was to see whether or not these different conditions impacted hospital admissions. Sorry, these different clusters impacted hospital admissions. And then the third aim was to look at whether or not there's this socioeconomic inequality in the impacts of these clusters on admissions. So in other words, does the relationship between multiple long-term condition cluster and hospital admission vary by someone's socioeconomic position? So onto the data. My main data set was the English longitudinal study of aging, which we've heard about quite a bit today, so I'm not going to go into any detail, but it's a nationally representative cohort study of community dwelling older adults in England. And it's also been linked to some administrative data sets. Again, we've heard about kind of linked administrative versus survey data. And in this case, it's been linked to a few. I'm here going to talk about the linkage to hospital episode statistics, which is an NHS administrative data set that includes a lot of different things. I I have data on hospital admissions, which we can break down into emergency and elective admissions. And I have data from 2008, which is around ELSA wave 4, which I use as my baseline wave, up till 2018. So about 10 years worth of follow-up there. Onto the methods. To identify these different clusters or patterns of multiple conditions, I use a technique called latent class analysis, which group people based on their self-reported answers to 20 long-term conditions which are collected in ELSA. So they're asked, has a doctor ever told you that you've been, or has a doctor ever told you that you have this condition? And they say yes or no. Then to look at the relationship between those clusters and hospital admissions, I use negative binomial regression model. So to look at a count of hospital admissions over follow-up. And then to answer this question of, is there that socioeconomic inequality, I looked at interactions between the cluster and a wealth variable. And this is household wealth, which is measured in ELSA. It's a very detailed, very comprehensive variable. It's a really good measure of overall wealth among older adults. So on to some results. Did I find any clusters? What clusters did I find? Luckily, I did find some clusters, otherwise I don't think I'm presenting this here today. I actually found 4 different clusters using the latent class analysis. So just to explain these little figures, the conditions in red are the predominant characteristics of the cluster. Those in orange are also present, but just not quite as predominant. So the first cluster that I found was, we decided to call it this age-related long-term conditions cluster, kind of all different conditions related to the biological process of aging, things like arthritis, osteoporosis, cataracts, these kind of things. The second cluster, again, probably one that you're familiar with, a cluster of cardiometabolic long-term conditions like diabetes, high cholesterol, hypertension. The third cluster was a psychiatric cluster, which was mainly psychiatric conditions, but there were also kind of slightly increased rates of respiratory conditions and arthritis, which is interesting. And then finally, this relatively healthy cluster, who most of them have 0 or only 1 condition, and they're still, you do find these kind of hypertension, arthritis, high cholesterol, these conditions, but they are just incredibly prevalent in older adults anyway. So those are the 4 different clusters, which means that we can then go on to ask, how are those different clusters associated with hospital admissions? So in this graph, I'm going to show you the predicted number of elective admissions over follow-up. It is stratified by wealth, so we've got the results for each different wealth tertile, and it's also got the results for each of the different clusters. So what I have up on the screen now is the results for the relatively healthy cluster. And we can see that the predicted rates of elective admissions remain relatively stable across the 3 wealth tertiles. But we can then go ahead and add in the results for the lowest and middle wealth group. And we can see that the people in the multiple long-term condition clusters have increased predicted number of elective admissions compared to that relatively healthy cluster. And when it gets interesting, we can then add in the results for the highest wealth group, and we can see that there's actually not that much difference in the multiple long-term condition clusters and the relatively healthy cluster when we're actually looking at that highest wealth group. So it does appear that higher wealth has some kind of protective effect against elective hospital admissions among people with multiple conditions, which is quite an interesting finding. We can then look at the results for emergency admissions. And this time my graph is not stratified by wealth, and this is because we didn't find any evidence of interaction. Instead, we found that people in the multiple condition clusters had increased emergency admission rates over follow-up compared to that relatively healthy group, but this remained constant across all of the different wealth groups. But we did still find evidence of a wealth inequality. So we found that even when you're accounting for which multiple condition group someone's in, people in the lowest wealth group still had higher rates of emergency admission, whereas people in the highest wealth group still had lower rates of emergency admissions. So what are the main takeaways from the presentation? Well, multiple long-term conditions are the rule rather than the exception among older adults. The challenges of multiple conditions are unique, and we need to be thinking about how conditions are interacting both with each other and with wider social factors. Multiple conditions don't arise at random. Common clusters have been found both in my study and across many other studies. There was some evidence of potential inequality in the impacts of elective admissions, or in the impacts of multiple condition clusters on elective admissions, but there are limitations. This is only one study. We need a lot more research to see if we find this effect in other populations, other data sets. And we also need more research to understand what the underlying mechanisms driving this inequality could be. So is it to do with kind of wider inequalities in society? Is it to do with inequalities in how conditions are managed kind of in primary care? These are things that we need to still figure out. And that is the end of the presentation, just some references to some of the studies. And thanks for listening. Feel free, if you have any emails to, any questions, to email me or ask them now either. It's great. So thank you.